Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Good afternoon. Come on in. It's Mrs. Thompson, correct?
Yes, that's me. Anna Thompson.
I understand you a Euro-VE been referred here due to recurrent migraines. Is that accurate?
Yes, unfortunately. This isn't a Euro T my first round with them.
Alright, I have a brief summary in front of me, but it'd be great if you could explain your experience, any prior treatment you've received, and any other relevant information.
Okay. It started about 2 years ago. I was dealing with a lot of work stress and suddenly one day, I had this blinding pain on one side of my head. It was debilitating. Over time, the migraines started occurring more frequently. Then, about 6 months back, they seemed to fade. But now, over the past 3 weeks, they're back and stronger than ever.
I'm sorry to hear that. Did your GP confirm these as migraines?
Yes, I had light sensitivity, nausea, and even vomited a few times. The GP said it was classic migraine. Honestly, the pain is so intense that sometimes I can't even think straight. I need to lie down in a dark room and just wait for it to pass.
Sounds tough. How did you manage the pain before?
I was given some prescription painkillers, and they advised me to try over-the-counter pain relief too. I also tried a cold compress on my forehead sometimes. It gave a bit of relief, but not for long.
Anything else?
Yes, I was also referred to a neurologist. They did some tests, including an MRI. Everything seemed normal. The neurologist prescribed a different medication and suggested some relaxation techniques. I even attended a few meditation sessions.
Interesting. Did any other treatments come up?
I remember being told about biofeedback therapy. I never got around to it. I also tried aromatherapy with essential oils. They were soothing but didn't always prevent a migraine. Some of my friends suggested acupuncture, but I haven't Euro T tried that yet.
Out of all these approaches, which one felt most beneficial for you? What helped the most?
It's hard to pinpoint. The relaxation techniques helped a bit in preventing, and the painkillers helped in managing the pain. But nothing seemed to completely stop them from coming back.
All right. Has anyone discussed potential triggers or factors in your daily life that might be contributing to these migraines?
Not in depth, no. I've tried tracking my diet and sleep, but I couldn't find a consistent trigger. I suspect it might be stress-related, but it's just a guess.
Well, we'll look into that further and try to find the best approach to manage and reduce these migraines for you.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Mr. Thomas Brigg? You can come through now.
Thank you.
All right, so your GP referred you to us about the persistent rash on your leg, correct?
Yes, that's right. I first noticed it a few months ago. It's here, on my calf. It's been on and off, sometimes it seems to be clearing up, but then it just flares up again. I showed it to my GP, and he thought it best if a dermatologist had a look. He also sent some pictures. Did you receive them?
Yes, I did. IA EuroVE reviewed them. Now, can you describe to me how it feels when it flares up?
It usually starts with a bit of burning sensation. After a day or two, it gets itchy, and then these tiny red bumps start to form. It gets quite itchy at times, and I find it difficult not to scratch. After a while, the bumps sort of merge, and it becomes this inflamed patch. I remember my GP using the term irregular for the rash's borders. Eventually, it subsides a little and then the cycle repeats.
I see.
It's odd though. I lived in South America for a few years, and I recall having a similar rash during my time there, but it disappeared once I returned home. I just assumed it was something to do with the climate there. But now it's back, though I've been here for years. There doesn't seem to be any trigger, not food or stress or anything of that sort.
And did you have any other medical issues? Any surgeries or past skin conditions to be concerned about?
Well, about a decade ago, I had a cyst removed from my shoulder. It was benign though, nothing concerning.
All right. Let's take a look at that old surgical site. Was it on this side?
Yes, right there.
Okay, this seems to have healed well. Now, coming back to the rash on your calf, it doesn't appear to be malignant or related to the cyst you had removed. But I can understand your concern. By any chance, have you ever had chickenpox?
Yes, when I was a child. But that's a long time ago. Why do you ask?
Sometimes, certain viral infections from the past can reappear in different forms, though I'm not suggesting that's the case here. I'm just gathering all the information I can.
I see. I had heard about antihistamines for allergies. Can they help with the itchiness?
Yes, they might help reduce the itchiness. But I wouldn't rely solely on them. The underlying issue still needs to be addressed.
Right. I also don't want this to spread or become infectious. Should I keep it covered?
Unless there's open skin or oozing, it's okay to keep it uncovered. But to get a better understanding of what's causing the rash, I suggest we do a skin biopsy. It'll give us more clarity.
That sounds like a plan.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. Emily, how did the wound dressing for Mr. Dawson go?
To be honest, Marie, I faced a challenge. I intended to use the new hydrocolloid dressing we discussed, but when I was cleaning the wound, I noticed it was more exudative than we had thought. I was concerned the dressing might not manage the exudate appropriately.
That's a valid observation, especially since we need to prevent maceration. With highly exudative wounds, sometimes foam dressings are better.
I thought of that and went ahead with the foam dressing. I just wanted to make sure he gets optimal care, given the risk of infections.
Good call. Next time, always feel free to double-check with me if you're unsure. We'll check on the wound tomorrow together.
Now look at question 26. Hello, Lucy. So, I hear you've been having headaches after school lately. Can you tell me more?
Yeah, usually after I finish my math homework. My head hurts right here, points to forehead, and my eyes feel heavy.
Do you use a computer or tablet for your homework?
Yes, my school gives us tablets, and I have to use it for almost 3 hours every day.
It sounds like you might be experiencing digital eye strain. Prolonged screen time can cause headaches, especially if you're not taking regular breaks. But to rule out other potential causes, we'll do a few more checks. In the meantime, try the 20-20-20 rule. Every 20 minutes, take a 20-second break and focus on something 20 feet away. It might help relieve the strain.
I'll try that, thank you.
Now look at question 27.
Mr. Thompson was referred to us earlier this week with complaints of palpitations and chest tightness. He's a 52-year-old marathon runner with a history of hypertension, controlled with medication for the past decade. He's been maintaining a low-salt diet and exercises regularly. An ECG showed some irregularities, but no significant ST changes. His echocardiogram, however, showed a slight dilation of the left ventricle. He's been put on beta blockers and will undergo a stress test tomorrow. Currently, he's stable, and his BP is well within limits. Around 3 p.m., he was given a mild sedative due to some anxiety. We're planning to do an angiogram next week if the stress test shows anything concerning.
Now look at question 28.
All right, team, let's discuss our approach to pediatric nutrition, especially for our long-term patients. I'm pleased to see many of you adopting the calorie-dense menu plans which help these children maintain or gain weight. Feedback from parents has been largely positive. Interestingly, our recent data shows that our afternoon snack initiative has led to a 30% increase in daily caloric intake for many children. However, I've noticed that some kids are still not getting the recommended fiber intake. Let's brainstorm some kid-friendly, fiber-rich meals for the next meeting. Additionally, it's crucial that we monitor and adjust for any food allergies or sensitivities. We've been lucky with few allergic reactions so far, but as we know, children's nutritional needs and sensitivities can change quickly. Let's stay proactive.
Now look at question 29.
All right, so updates on the new admits? Alan, can you cover for us?
Certainly. We have young Timothy Park in room 8. He's a 7-year-old boy who was admitted due to a severe asthma attack during his school sports day. He has a known history of exercise-induced asthma, but this episode was more intense than usual. He's now on nebulized albuterol and is responding well, but we'll keep him for observation and adjust the frequency based on his peak flow readings.
Got it. We need to educate the family again about trigger management.
And what about his discharge?
The plan is to reassess his inhaler technique and possibly introduce a preventer inhaler. We are also looking to refer him to an asthma education class. The school will be informed to ensure they are well equipped to manage any future episodes.
Excellent. We will discuss this further in the evening rounds.
Now look at question 30.
Mr. Fitzgerald, how have you been feeling recently?
My daughter insisted I come, doctor. I've been feeling quite tired lately and more forgetful.
All right, and have you had any falls at home?
Just a small one in the kitchen last week. No harm done, but my balance isn't what it used to be.
That's not uncommon at your age. As for the forgetfulness, there are many factors, from sleep patterns to medications that could play a role. Let's run some tests to rule out any underlying issues.
I was worried about dementia or Alzheimer.
It's good to be cautious, but it's also essential to remember that age-related memory changes can be entirely normal. Let's assess everything, and if needed, we can discuss strategies to help you manage better.
Thank you, doctor. It's reassuring to talk about it.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1.
Today we're joined by Dr. Emily Green, an endocrinologist and expert on type 1 diabetes in the UK. Dr. Green, can you enlighten us about type 1 diabetes and why there is increasing concern about its prevalence in younger age groups?
Certainly. Type 1 diabetes is an autoimmune condition where the pancreas stops producing insulin, a hormone that regulates blood sugar levels. Unlike type 2 diabetes, which is more associated with lifestyle and obesity, type 1 often arises in children and young adults. We've seen a rise in its incidence in younger populations. The reasons aren't entirely clear, but genetics and environmental factors might be contributing.
What are the symptoms, and why is early detection crucial?
Symptoms include increased thirst, frequent urination, fatigue, sudden weight loss, and blurred vision. Early detection is critical as it can help manage blood sugar levels better and prevent severe complications such as diabetic ketoacidosis, which can be life-threatening.
Are there concerns in the UK regarding type 1 diabetes?
Yes, indeed. With increasing cases among younger individuals, there's a strain on the healthcare system, and early education becomes essential. Schools, parents, and caregivers need to be more informed to detect and manage symptoms early on.
Could you share a patient's story with us?
Of course. Last month, I met a 9-year-old boy, let's call him Jamie. His teacher noticed that he was always thirsty and frequently needed bathroom breaks. Initially, everyone thought it was a urinary infection, but further tests confirmed type 1 diabetes. Early detection in his case allowed his family to make necessary lifestyle adjustments, and Jamie's now managing his condition well with insulin therapy.
What challenges do patients and doctors face in managing this condition?
There's a psychological impact. Being diagnosed at a young age means lifelong management. Patients like Jamie must routinely check blood sugar levels, administer insulin, and constantly watch their diet. From a medical perspective, ensuring consistent blood sugar levels, preventing hypoglycemia, low sugar, and long-term complications are challenges.
What about adult-onset type 1 diabetes?
It's less common but does occur. Adults might mistake it for type 2 given the age of onset, which can lead to incorrect treatments. So, it's essential to differentiate between the two types.
How can we address the rising cases of type 1 diabetes?
Research, awareness, and early education are key. We need better understanding of triggers, potential interventions, and genetic factors. Schools and parents should be educated about early signs. There's also ongoing research into islet cell transplantation and artificial pancreas systems, which could revolutionize treatment.
Dr. Emily Green, thank you for shedding light on this important issue.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42. Good afternoon, everyone. I am Dr. Lisa Carter, a physical rehabilitation specialist, and today I'm here to shed light on the journey of post-stroke recovery. Through the tale of one of my patients, let's understand the significance of physical rehabilitation post-stroke. Firstly, when we say physical rehabilitation after a stroke, we refer to specialized healthcare dedicated to improving and restoring functional ability in individuals who have suffered a stroke. The journey is not just about regaining lost abilities, but also about relearning old ones, and sometimes even exploring new ones. I always liken doctors to detectives. The doctor asks, "What caused this?" While I probe, "How can we navigate this?" Let me share the story of Jane, a 45-year-old woman who suffered a severe stroke. The left side of her body was significantly affected, leaving her unable to walk or even hold things properly. The lively, independent woman who once danced her way through weekends was suddenly confined to a bed, feeling trapped in her own body. The first time I met Jane, she was incredibly despondent, questioning if she'd ever be able to live a normal life again. Many saw her condition and thought, maybe she'll always need assistance. But I looked at Jane and thought, where can we begin? Rehab is not just about physical exercises. It's about understanding the patient's emotional and psychological state. Jane loved dancing, so we started there. Instead of basic leg lifts, we tailored exercises around dance movements. Slowly, with the support of bars, she began to make her first dance steps. This is not to say that the journey was smooth. There were days Jane cried out of frustration, especially when she felt she wasn't making progress. The key was to show her the smaller achievements, like the first time she could balance on one foot or when she managed to complete a half twirl. 6 months into therapy, a significant moment occurred. Jane danced. Not as flawlessly as before, but with a spirit that was unbreakable. That day, she realized that while the stroke took away certain abilities, it couldn't take away her passion. Jane's story doesn't end with her dancing. She's now an active member of stroke support groups, helping others see the light at the end of their tunnel. Her strength wasn't just in her recovering limbs, but in her resilient heart. So, when we discuss post-stroke physical rehabilitation, remember it's not just about the exercises. It's about the spirit, and as healthcare providers, we don't just guide the recovery of limbs, we foster the recovery of hope and spirit. Thank you for your time today. The journey of healthcare is a partnership between professionals and patients, and stories like Jane's are a testament to this beautiful collaboration.